Today I'm going to speak on nuances of parathyroid surgery and intraoperative use of intra-PTH hormone. As you all know, parathyroid surgery is the most challenging surgery in clinical practice. The first conventional parathyroidectomy was conducted by Dr. Felix Mandel almost a century ago. Since then, a lot of technical advances have taken place like intra-PTH, image localization, and high-resolution ultrasonography. And it has led to the other approach like minimal invasive parathyroidectomy, which is equally successful as that compared to bilateral exploration. There is a universal agreement that there is a universal agreement that surgery offers a permanent cure for primary hyperparathyroidism. Surgery is known to elevate symptoms of patients. It also it also causes reduction or reversal of end organ damage, like fractures or renal stone formation. It also causes improvement in quality of life of the patient. All patients of symptomatic primary hyperparathyroidism are indications for surgery. In asymptomatic patient, the fourth NIH guidelines clearly states that patients who have serum calcium more than 1 milligram per deciliter of upper limit and age less than 50 years, with bone mineral density less than minus 2.5, with evidence of renal disorders like renal stones or 24 hours urinary calcium more than 400 milligram per day are candidates for surgery. In surgery, before surgery, preoperative imaging plays important role. It is not a diagnostic modality, though it helps us to identify abnormal glands and the location of the abnormal glands that allows us to decide about approach of surgery depending on the involved gland. As you all know, there are a lot of localizing studies which are available. The most important of them being USG, System EB, and 4D CT scan. The previous speakers have elaborated on the benefit of all these localization studies. In surgical practices, we mainly use ultrasonography, System EB, and 4D CT scan. Ultrasonography has an advantage of picking up concomitant thyroid pathology, but it cannot pick up the retrosternal, that is mediastinal or retroesophageal ectopic glands. System EB also has some limitations where it can give false negative results based due to presence of multiglandular disease or thyroid or multinodular goiter, presence of multinodular goiter. Ultrasonography and System EB when used combined have an accuracy of almost 95%. There are other imaging modalities like 4D CT scan, which gives you excellent anatomical details and can help in our surgeries, especially in ectopic surgeries like mediastinal surgeries. There are mainly two surgical approaches which has evolved over many years. One of them being bilateral neck exploration. It is based on exploration of all four glands, whereas the other approach, that minimal invasive parathyroidectomy, involves only selective dissection of single parathyroid gland. The choice of approach will depend on be dependent on the patients and the imaging studies. In the patients of positive imaging with solitary adenoma, minimum invasive surgery is preferred. However, in patients with multiglandular disease, with hereditary parathyroid hyperplasia and non-localizing imaging, bilateral exploration is the choice of surgery. In bilateral neck exploration, visualization and identification of all four glands is mandatory, where the decision is made to resect abnormal gland after identifying all four glands. In bilateral neck exploration, identification and protecting laryngeal nerve is also important step. Bilateral neck exploration is indicated in patients of multi-gland disease, hereditary primary hyperparathyroidism, and patients of non-localizing discordant imaging. It involves large incision and extensive dissection. However, the success rate of bilateral neck exploration is more than 95% with less than 3% complications when performed by experienced surgeons. Whereas minimal invasive parathyroidectomy mainly takes the advantage of a small incision, and it is image guided, single gland excision. And here mainly intraoperative IOPTH adjunct is mainly used. When performed by experienced surgeon, the curative rate has extended from 96 to 98% and complication rate are less than 1%. So, however, what is minimal invasive surgery? In literature, there are more than 75 definitions of minimal invasive surgery, but in practically, we use mainly three approaches that are minimal incision parathyroidectomy, which is also known as focused parathyroidectomy, endoscopic parathyroidectomy, and radio-guided parathyroidectomy. The minimal incision parathyroidectomy or a focused parathyroidectomy is mainly done is can be done as a uh, as a small procedure where it is image guided and it reduces the duration of surgery. It causes less dissection and causes less chances of injury to the recurrent laryngeal nerve. It is always image guided and and it also uses intraoperative adjunct like intraoperative IOPTH. Minimal invasive endoscopic parathyroidectomy was first done in 1996 and it was mainly pioneered by Dr. Gagner. There are three approaches. That is lateral approach, which uses three ports along the anterior border of the sternocleidomastoid muscle. Another approach is a suprasternal approach. However, of late, transthoracic approach of minimal endoscopic parathyroidectomy is used mainly for treating ectopic parathyroids, mainly mediastinal parathyroid adenomas. It is technically challenging surgery and has a long learning curve. The another minimal invasive surgery which uses radio-guided parathyroidectomy. Another minimal invasive surgery is radio-guided parathyroidectomy. It is pioneered by Dr. James Norman of USA. Here, here we use a radio probe which takes into account the technetium which is given 1 hour prior to the surgery. Initially, the first background count is checked, and subsequently during surgery, in vivo count of the parathyroid tissue is checked. And subsequently, after excision of the parathyroid tissue, ex vivo count is also checked with the handheld probe. MRIP has a 20% rule, that is ex vivo count of the resected parathyroid tissue, and the ratio of ex vivo count to the background count should be more than 20%. If it is more than 20%, then it confirms abnormal parathyroid tissue and confirms cure during the surgery. Intraoperative, there are a lot of intraoperative adjuncts which are used to facilitate minimal invasive surgery. The adjuncts which are mainly used are IOPTH and frozen section, which will confirm the identity of resected tissue. Methylene blue or near infrared fluorescence, infrared fluorospectry are used to enhance visualization. When injected, methylene blue gives a blue hue to the abnormal parathyroid gland, and it makes easy for surgeon to identify parathyroids during dissection. Intraop ultrasound and jugular venous sampling can also be used intraoperatively in difficult surgeries to locate the site of the surgery, to locate the offending parathyroid gland. Recurrent laryngeal nerve monitor can also be used to protect recurrent laryngeal nerve. Intraoperative parathyroid hormone is the most important surgical adjunct used in all parathyroid surgeries. It takes the use of a short half-life of parathyroid, which is 3 to 5 minutes. And also rapid parathyroid hormone assays are available with completion time of 8 to 20 minutes. Intraoperative parathyroid hormone can predict intraoperative cure. It can also use as a localization tool, or it can be used as a biochemical frozen section. When while doing a parathyroid surgery, after resection of the offending parathyroid adenoma, samples are sent, intraoperative samples of blood are sent to detect levels of parathyroid hormone. A drop of 50% intraoperative PTH from the highest level or pre-incision level within 10 minutes can confirm cure of surgery. Here is a case of focused parathyroidectomy where a patient of 54-year-old female had a solitary adenoma as detected on ultrasonography and system EB. When operated with a small incision, After resection of the tumor, the preoperative IOPTH was 325 and post 10 minutes IOPTH was 101. However, we waited for another sample after 20 minutes as the PTH has not dropped down to the normal level. After 20 minutes, the PTH level was 34 and within normal, conveying that it is a single adenoma and not multiglandular disease. However, if the drop would not have been below 100, we would have further extended our dissection and searched for the other parathyroid glands. This is one of the case of minimal invasive parathyroid surgery where a 17-year-old female had a mediastinal ectopic solitary thyroid adenoma as detected on 4D CT and MIB scan. We had used a transthoracic approach where ports are put from the lateral aspect of the third, sixth, and seventh intercostal space to reach into the thoracic cavity. Here we are identifying the adenoma, which was previously demonstrated on CT, that it is between the left major vessel and phrenic nerve. While dissecting, it is important to safeguard the surrounding vital structures. Here you can see we are dissecting in the groove between the phrenic nerve, which is above, and the great vessel, which is below. As the dissection proceeds, there will be a visualization of parathyroid adenoma, which was almost around 1.5 centimeter in diameter. Here we can clearly see the parathyroid adenoma situated there. Minimal invasive surgery has made easy to reach this mediastinal area, and it prevents morbidity in patients like sternotomy. This is a picture of post-excision bed from where we had taken out the adenoma. Pre-operative IPTH level was 323. After post 10-minute IPTH level was around 60. At the end, we'll make surgery is the only definitive treatment for primary hyperparathyroidism. Diagnosis of primary hyperparathyroidism is biochemical and not image-based. Bilateral exploration and minimal approach are equally successful. The success of parathyroid surgery is dependent on surgeons' hard-earned experience and skill, and nothing can substitute that. With this, I complete my talk. Thank you very much.